So week 9, we're going to go over the child with musculoskeletal or articular dysfunction, and we're going to go over the neuromuscular or muscular dysfunction. So they're a little bit the same, a little bit different. We're going to go into all of that. Discussion question 6 is going to be due this week, and we do have a dosage calculation. It is 1% of your grade, so I don't care if you use the handout or if you write it, as long as you sent me all the pieces of it. So I've had that question, which way do I want it? Whichever way it's easier for you to do. Okay. So get that in. Yes,
That was a question I was going to ask because I was writing it because I do it better writing, but
that's fine.
things don't
That
fit
is
in the square. So I was like, okay, maybe I need to ask if I can do it a different way.
that's what many different students have said. That's why I start out with that. Let you know, yes, you can do it. Just send me each page as an upload, okay? And all of those will go in. It's an unlimited upload thing for you because of that. So that's there for you. Remember the project? I've mentioned it earlier. I'll mention it again. If you haven't done it, make sure it's done by Sunday. There will be no send backs, fix it, make it better. Send it in once and I will grade it for you. It is a 6% of your entire subjective grade. I do know we've had many homework fails because that project's not in. Unless you're in high 90s, is your grade right now, it can put you below that 78 when we combine those key graded assignments with the subjective or the homework portion. So be aware. Also, if you didn't get a perfect 100, go back and look. What did I tell you? If you want to increase your grade, go ahead. Put in a revision. Let me know that you've done that revision, and then I'll go back and regrade it. And this is only before Sunday. After Sunday night, 11:59 Eastern Time, I cannot accept any more of them. So I do this. Dr. Brown knows I do it. It's just to try to help you learn APA a little bit better, because I know many of you do want to go on for your BSN, MSN. Maybe you're crazy in a PhD like me, but I know a lot of you like want to be that nurse practitioner. I know that was always my goal. And then I realized with the RA, I couldn't walk. So it's all right, I'll be a teacher, but I've always been that teacher. Next Saturday, week 10, after the exam, I will be doing a HESI Q&A. I have a PowerPoint. I go over it. I do it every quarter for y'all. It's to help you think. I do it at 2 p.m. Eastern Time. I do put it up into, of course, my YouTube channel, and you get the recording. It's something extra I do, trying to go over the concepts that I know are on the HESI. Now, I don't know questions, but I know those basic concepts. So I try to describe them in a manner that you can understand so that you all can get the best HESI grade you possibly can. Because I know everybody's always worried about the HESI. You have this A average and you do the HESI and you get an 800 and you're like, but why? So I think you'll be surprised. My mean HESI grades are over 900. So yes, you can do it too if you put in the effort and the time. I also am going to be sending you 2 100 question SE Cahoots. Again, going over all of that concepts and for you to practice, practice, practice. So you put in some time, you guys can also get a 99.99. Last quarter, I had one girl who struggled. She was rated at 78 all quarter. She worked with me for her third exam and the HESI. She got a 99.99. So, yes, you can do it. It can be done. You just got to put in the work and the effort. I'm handing it to you. You have the information. You just have to look at it and understand it, okay? So, any questions about anything? All right. So we still have some reviews still going on through today. Actually, the last one is at 6 o'clock tonight with Professor Morris. If you want to go to that when we're done, but of course, it's going to be posted in that one announcement that I'll just keep editing with all of your recordings there for you to look at. So let's open up and start going. Remember, any questions as we're going along, please, if you're not understanding, please let me know, and I can, explain it in a different way. So muscular or articular dysfunction, this has something to do with bones not being where they should, whether they're broken or like that right upper corner, that's a dislocated hip from birth. That's called a DDH. And how do we get that hip socket, and that ball of that femur back to where it should be? And it's called a Pavlik harness. We're going to go into that more, but you can see where this chapter is going to. Now you think of an immobilized patient, client, you're thinking more of the elderly, right? Well, you'd be surprised how many children have many conditions that they are immobilized. They're not able to be mobile, getting around for many different things. We know that today we've got so much more medical knowledge that we can keep these children more mobile for longer periods of time because of what we've learned. There's congenital defects, degenerative, osteogenesis imperfecta, I think is the big one that I think of with degenerative. It's a brittle bone disease, and we know that a child who's immobilized, many things happen. Now, if they're in bed, can't move, we always worry about things like bed sores and atelectasis and foot drop. All of those things happen in children too. We want to prevent blood clots and in the legs and in the lungs and the swelling. So we need to be aware, good positioning, turning, and good nutrition. Now, what about the kid underneath? Children really understand their environment around them, and they are stuck in a room, in an area. They can't get out. They hear stuff. They can't get to it. So they're really secluded. Many of these children are in a room and they can't even, the doors are shut for whatever reason. So they don't have that environmental stimulation. They don't have, that things to do, right? So at this level of child, we need to be aware. We don't keep them stimulated. We don't keep them not entertained, but giving them things to do that will help them, quote, pass the time, right? You're going to have a child who's going to be very frustrated, angry, and they are going to lash out at you. And it's only right that they do because of their situation. And they do many times start sucking their thumb. They'll start wetting the bed when they've been potty trained. All of those things can happen with immobilization. Now, on the other hand, what about the family left at home? You have a mother and father, or a mother, or just a father, who has to sort of balance between work, home, and then the child in the hospital. So remember, there are other people involved in this whole predicament of an immobilized child or a child who's in the hospital long periods of time. Today we're doing a lot of great things with families. I know the pediatric facility I worked at, every single unit had a specialty, whether it was the neuro floor, the GI floor, the cardiac floor, all had family groups. And those family groups shared what they were feeling together. And they actually could help each other in situations of finding equipment or whatever they needed. It was a great, great experience. And they got really close. They became another family within themselves. So let's start talking about muscular type of injuries that can happen. Well, we know that we have a lot of soft tissue injuries. I mean, I was the queen of getting sprains. I mean, my ankles were always, twisting the wrong ways. And we know it happens with sports. It happens, just running around, and then falling and twisting the ankle, the knee, the finger, the toe, whatever. Now, contusions are, it's a bruise, right? No big deal. Remember, you don't see all the blood on the outside. Sometimes it's on the inside, and now it's occluding blood flow. So even though it's a bruise, doesn't look bad, Remember to check neurovascular signs always distally, okay? Because it could impede upon that circulation, and then you're not getting blood flow where it needs to go, death of tissues, you could lose fingers, toes, whatever, all just because of a bruised area, especially if it was due to some sort of crush. I've seen a lot of things fall down on children, TVs, dressers, lots of things. Now, dislocating of the joints. I think the biggest one we think of, I know I've seen many of them, is a nursemaid elbow, where you take the child and you swing them around by their hands and their elbows because of the very soft tendons and ligaments they pop out of their joint. And they come in, their arms are hanging down, and it hurts. And we just look at them, go click, it's back in. We put them in a nice sling, and we just tell them to take it easy and not to do that again. The other person, a group of people that end up with dislocation can be the Downs child. They are very, very flexible. If you've ever met a Downs child, they can lay on their back on the floor, put both feet behind their head, and they can actually pop their hips out of joint. Remember, if they do that, it can cause a disruption in blood flow and nerves and create more problems. It's something we should not encourage. Sprains. How many of you had a sprain? I think they hurt worse than a fracture, don't they? All of a sudden, let's say you're walking outside, you see some, look at something, your ankle hits a uneven area and it hits to the side and you can feel it swelling almost immediately. It is the ripping of those tendons and those joints in there. And it's something that I think it's worse to have that than the fracture for sure. Strain is when you do a same thing over and over and over and over and over again. This would be a child practicing, let's say, for it's the Olympics coming up. So maybe gymnastics or maybe running or jumping, all of those things, doing the same things over and over again. And they hurt just like a sprain, but it's not a ripping, it's just the overuse thing. So when we feel these things, you fall down, you sprain a thumb, playing volleyball. I can't even tell you how many thumbs I sprained doing that. Remember, the first thing is to number one, stop, rest. If it was my ankle, I put my foot up right away in the air because I know it was swelling. And then my coach would come, give me ice, we'd wrap an ace bandage, and we keep it elevated. So remember the word rice. Okay, rest, ice, compress, and elevate. And then in the end, we're going to immobilize it some way. No, years ago, we didn't take the sprains and immobilize them, but we've learned it actually does better by immobilizing, putting them on some sort of cast or posterior splint or something, and it will give it that rest it needs. Fractures are very common in children. What do you do when you fall down? You put your hands out, right? So what can be fractured? Bilateral wrist, right? Radial ulnar. And I've seen bilateral fractured wrists. Remember when the hoverboard first came out? It was the neatest thing. The kids were there riding it. That Christmas, I had two young boys come in, bilateral fractured radial ulnars because of hoverboards. So how could have we have prevented that? Well, just like with our discussion question, proper sports equipment. They do have wrist, braces. They do have helmets and knee braces to put on so that if they do fall, they're not going to hurt themselves. Because kids always put their hands out first when they fall. They always protect their head. It's just like a cat. You drop them, they land on all 4 feet, right? Kids, same thing. One of the things that we need to be very alert about is infants. An infant who comes in who has an injury that's a fracture takes a lot to fracture an infant's bones. And I'm going to go into more about healing times and whatnot. But, infants, they're so soft and so flexible and bendable to be able to fracture a bone. It mostly is child abuse. And remember, as a nurse, and if you are a pediatric nurse, your first job is to watch out and protect the child in your care. So there's a bunch of different types of fractures. We have that simple one that they come in, the bones are almost pretty well aligned. They're just cracked, whether it's diagonal or straight across or partial. We put a cast on them. Now, there are also fractures where the bone comes out the skin, and now you have the chance for infection. So this child is going to need IV antibiotics, at least the first couple days, because that bone can get infected, and then we're going to be worried about osteomyelitis. And that could end up systemic, and septic, because it will go into the blood system. So we take it very seriously. Complicated is that, let's say, a rib fracture. It goes in and punctures the lung. That's a complicated one. It affects an organ. Comminuted fracture, little pieces. It's like a shattered bone in there. Can you imagine how much those little sharp edges hurt? And then avulsion is tendons and ligaments pulled away. And one not mentioned here is called a spiral fracture. That is actually child abuse. It's when they take the hand and turn it and twist it and pull, and you're going to see a twisting break. That is child abuse. Now, our concerns about broken bones in children have everything to do with they're still growing. And in the bones are our growth plates, and they're right at the tip of the bone. And if we get a break in here, you could have a crooked hand, finger, leg, arm, it doesn't matter, wherever that bone is, and it might be shorter than the other one. And our goal is to keep that both sides equal, right? You don't want to limp. You don't want one arm longer than each other. So how do we treat a growth plate fracture? Well, that child's going to go to the OR because we need to really line them up, and we put, it's called an open reduction internal fixation, plate screws. Let's line it up really good. Now, as I said, healing and children. Look at the neonate. That is your first 28 days of life, neonatal. And then it goes into the infants, which probably about 3 weeks. They heal very, very quickly. If you look at that picture there, that's a child probably with a club foot on the right side. That other ankle looks a little crooked. So we're going to be just putting cast on them, repositioning that leg. And guess how frequently we're going to be changing the cast as that is making its way into where it should be positioned? Every week. We do it every week so that we get it and change it as it goes, and we start as soon as possible because of how quick they heal. Most kids that we see, 4 weeks cast on and off, their bones are healed. Me and you, oh, it could be 3-4 months before it's healed because we don't heal as quick as the younger child. So you get the kid in complaining, fell off the monkey bars, complaining of pain in the wrist, hard to move their fingers because it's painful, swelling. What do we do? Well, only are we going to do that x-ray to look at it, but we always are going to be suspicious. Now, I know this is hard, to look at a child and say, well, maybe the parent did it, but I'd rather be safe for a child's safety, to make sure that they're not getting hurt. I've seen child abuse, and I've seen some really horrific child abuse in my career. So I have one of them, a 3-month-old, is the one that I caught and started the whole let's look at it. And it was not only the 3-month-old, it was the twin and a 2-year-old son in the same household. So I ended up keeping a whole family of children safe. So as we're doing the history, how did the kid do this? Well, mom's talking, saying everything. Sometimes older kids might want to tell you, which is actually good. But we get a chance sometimes in the x-ray room or somewhere where the parent go get a cup of coffee, and we got the kid alone. I would ask, so how high was those monkey bars? Ask questions related to it to see if the story's sticking. Because remember, child abuse is something that the injury does not match what their history is telling you. That is the clear definition of an injury of child abuse. Now, what do we do for fractures? We want to reduce them, immobilize it, because we want the function there, and we don't want with deformities. That fracture right there wouldn't be considered growth fracture. We would make sure it's lined up, put a cast on it, and then they'll follow up with orthopedics. Now, put a cast on a child, that's all we have to do, right? Send them home. They're going to be good. Well, no. There are some casts where the injury underneath swells a lot. And when it swells, now it's squishing down on your blood vessels and it's decreasing blood flow that's going on, right? And because of that, you are going to have some death of tissue. Now, that right arm is the extreme case, but it can happen. Put a cast on, ignore it, and leave it alone, and it swelled. Well, you could lose an entire arm, an entire leg. You can lose toes, fingers, all of those things. So we need to do all these 6 Ps that we need to teach the child and the family. Look for pain. Is it getting more? Is the color of the skin getting paler? It's decreased blood flow. Pulselessness, well, obviously nothing's getting there, no blood. Paresthesia, now the nerves are being affected and it's getting, you can barely feel it, then you can't move it, and you feel all this pressure. Well, if we feel those things, what did that child need to do? Well, they need to go back where they had the cast put on. They need to call the doctor. And it is almost like a compartmental syndrome, and it does need care as soon as we can. Now, casting for children is actually where I worked was fun. We had yellow, orange, green, 2 types of pink, red, army, rainbow. I mean, we had colors, 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 colors. And kids, when you say you could pick a color, doesn't that distract them from the point where they're getting a cast on a broken arm and they got to put the cast on? They're just excited to get that color. So we do those. We do have pediatric orthopedic technicians that put these casts on, specially trained, and then our job. How do we take care of that cast at home? Now, one of the things we need to remember, these casts can't get wet underneath. Can I tell you how many kids left the ER getting a cast on in South Florida, went home, put their bathing suits on, and jumped in the pool? And how many parents wanted to shake those children and say, oh my goodness, what did you just do? Because they've got to come in and get a new cast on immediately, because it has to do with the water underneath and fungus and algae and whatever else can grow in there. So we don't want that. We also give them bags for showering or bathing where we can cover the cast. And of course, skincare. Nothing inside, no lotion, no powder, no pencils, no hangers. A cool little hair dryer works actually really well. And that sometimes it's what they need to do. And these children need to know the consequences of that. I mean, just think about a hanger in there scratching the skin, cause a big sort of laceration or even a scratch that gets infected. So sometimes we have to put a kid in traction. Now, one of the big things that we put them on traction for is a fractured femur. The femur breaks and there are big, strong muscles in the thigh, right? So it pulls now that bone in either direction. And those ends of those bones are going to create a lot of pain, a lot of swelling, and it also can cause a decrease in blood flow and, can cause a lot of problems. Now, years ago, we used to put stymon pins in here and do traction for a month. Today, what we do is we put rods down these femur. And that rod, it's not done immediately after the injury. We have to have them stable for a couple days, and then we'll put in the rod. So we in this traction here. That bottom picture is called a Buck's traction. It allows those bones to go together, and it helps with pain, and it keeps blood flow going where it needs to go. It actually starts healing, and then they can do the surgery when they need to. Now, one of the big things, as I said, it's all of those muscles spasming, pain, and we don't want to have, again, that deformity going on there. These below are skeletal traction. Now, the box traction is skin. It's does no pins in there. There's a little boot we put on, and with an ace, we'll hold it into place, and it works really well. These are like the one on the left with the girl with the sticking up head is into the head. And what we use that for is usually a fractured cervical spine. And I've seen it work really well. The one on the right, actually, probably this girl had surgery. Could have been some sort of, they have this atlas axis, those two top bones are a little bit, the flow isn't good, and they need the surgery to open it. And that's what this looks like to me. So what's the more traction? We have bucks traction, which pulls the leg, okay? And if you notice at the end, there's a weight hanging there. Now, you can never take off the traction. What happens if you take the weight off that traction? It's a chance that that bone will slip and now will come undone, right? We don't want to go backwards. We want to keep it healing the way it is. So 24 hours a day, 7 days a week until we get it fixed, that femur, we need to have those weights hanging freely. So that's bucks. It's just one pull. The other thing we have is Russell's, and there's one extra piece to it. It's that underneath the thigh, like that little sling, and it's a physician's choice. Bucks, Russells, they both work about the same. Now, that little girl down there to the right is in Bryant traction, and she has developmental hip dysplasia. That little harness we saw on that first slide, the Pavlik harness, didn't work. And these children have to be less than 30 pounds to do this. And then after that, they ended up needing tendinotomies, surgery to open up and get that hip back in the joint. But it actually works pretty good. They're in bed, their hips are up, and they're like in a right angle sitting there. Now, another thing we do is what we call a distraction fracture. Sometimes we have born with a leg, an arm, usually legs though. One is shorter than the other. So we need to get the one leg as long as the other. And they can break the bone, put this open, this external fixation device, and then we'll allow those bone pieces to heal. And it is painful. There are metals that go inside of it, but kids tolerate actually this really well. And they actually get that limb so that they're not going to be in limps all the time or special shoes all the time because now the legs are the same. Can you imagine if you were always limping? You'd have back problems, posture problems, right? All those things. So the earlier we can fix it, it's actually better. Now, sometimes children are born without a limb. I've seen lower arms, I've seen lower legs. I've also had a friend whose daughter was born with one leg that didn't have a fibula. Now, there's nothing that we could put there to replace the bone. So she had to have a below the knee amputation. Now, other ways that we could have an amputation, crush injuries, things like that, infections, all of those things. As an adult, what do you look for after an amputation? Isn't all that phantom pain, the pain management, getting a prosthesis, getting them physical therapy, all the same here. Now, sports and injury. Now, kids love competition, don't they? They like to win. I won, right? And even if they didn't, sometimes when they're younger, you go, yes, dear, you did win. You did good. Well, as they get older, they really earn it. They love it. It's competitive. Sometimes they like to hit and push and shove. They just like to extend themselves. Remember, children with sports need good equipment. They need to be stretching, getting ready for it, and then prevent those overload injuries, making sure they don't overdo it. So overdoing it. This is that repetitive, repetitive, repetitive. As I said, it could be track, it could be bicycling, it could be gymnastics, whatever we're doing, the same sort of, motions over and over again. And it can cause those strains there, right? Overuse. Now, I mentioned it already, but here it is, that developmental dysplasia of the hip. It's also called congenital hip dysplasia. And if you notice, the ball of the femur should go up into the hip firmly. Well, in a baby born that doesn't, that hip will be anywhere up to here. What happens to the leg on the affected side? The leg is shorter, isn't it? And if you turn them over, because the hip's up here, the folds are going to be crooked also. Usually the gluteal folds there, okay? They do say it's girls more. Now, what does the pediatrician do to a newborn infant when we first bring them to the doctor, first visit? Don't they take their knees and put them up and down and backwards? They're looking for the positive ortolani, positive Barlow, hearing clicking, looking at the folds, looking at shortened limbs. Because why? We want to start them on treatment as soon as possible because they heal so quick as infants. Well, what does a Pavlik harness do? What is our goal? Well, it's called an abduction of the hip, okay? That is the word, abduction. And usually we can get them, fixed up pretty quickly from birth to 6 months, all right? Now, if after 6 months we can't, we do have that Bryant traction, but sometimes they put them into a spica cast to hold it into place. And as I said, older kids going to have those tendons cut, pushed in, and do more of a surgical repair on it. Clubfoot, I've mentioned it already. You do not need to know all the different little names and what they are. It's a crooked foot and ankle. In, out, up, down, doesn't matter which way or how severe. They're all something that needs to be fixed, and we do it with the Ponseti method, which is those castings. Remember, it's a casting. We start as soon as we possibly can, and we put one cast on every week. So you can see 1, 2, 3, 4, 5, 6 weeks, and they did a lot better. I've actually seen kids, little infants, get out of these casts. Mom walks in, they said to put it on yesterday. Here's the cast and here's the kid. I don't know how they got out of it. So they are wiggle butts, as I call them, and they can get out. So warning parents. Now, as they get older, because they've had this correction at birth, they do need good follow-up. They might need proper shoes when they start to walk. So that's something will be, as they grow until they get into adulthood. I mentioned it already, osteogenesis imperfecta. It is inherited. It's some sort of connective something. But what it is these bones snap really easily. In my career, I've seen one. And I was afraid to even put my hands underneath and lift them up to change the bed. What we used to do is put a baby blanket underneath, a nurse on one side, one on the other, and we pick up together. So it's one holding the whole child, changing underneath, putting them down. They really break that easily. Now, there's no cure. There's nothing we can do. They are going to have broken bones. It's just what it is. Yeah, you can give some IV biphosphonate, calcium, good diet, vitamin D, all of those things. Our goal with this is to have them in a functional position. They can get out of bed and into at least a wheelchair. These kids usually don't walk. Many of these kids are in wheelchairs. And it's interesting, when I worked at the pediatric facility, these kids would be in electric chairs and their little fingers would get them rolling down the hall, and you'd hear this beep, 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 beep. and these kids would go past you into the cafeteria to get some food or whatever they wanted. They were very alert, but their bodies didn't meet their minds. They're very smart little children. Now, late calf birth disease. It is an aseptic necrosis of the femoral head. That means no infection, and the femoral head is dying. It is white males 4 to 8. Sometimes one bone, sometimes two. Somehow circulation stops. We don't know all what happens on it. What we see is all of a sudden this kid will be stiff, especially if they're sitting for a while, get up, and it will be similar to a juvenile arthritis, but it's a little different because it's the one side and there is no history of any trauma. They didn't fall. And when we do an x-ray, we're going to see fuzz. If you can see it, there's fuzz around the top of the ball of the head of the femur. And we go, how do we treat it? Well, we need to rest the hip. We don't want any movement, all of that when you're walking. No, we want them on rest, no weight bearing, and NSAIDs. It's an anti-inflammatory, right? And sometimes they'll put these kids on Buckstraction. Now let's go into some spine abnormalities. Kyphosis is the upper neck. This is the humpback, as we call it. We see this a lot in the elderly where they're just bent over on their shoulders. That is kyphosis. Lordosis is an underneath of that lumbar spine. You sort of like their back is up and then the buttocks. So they're sort of like walking, you know, you can see how their shape could be. Scoliosis is the one that's the most common. It's what we call an S-shaped curvature of the spine. And there's from mild to severe. Now, mild ones, if you see that curvature of the spine, what happens? Remember, there's ribs attached, right? And that curvature can cause a compression of lungs. So severe scoliosis is going to compress one of the lungs. So it's going to need something to fix it. Now, we usually see scoliosis right there after that pre-adolescent growth spurt. Remember that 12-year-old area of 14 where they go 20 to 25% of their whole height. That's when we see it. All of a sudden, we're going to see the elbow, one's down. We're going to bend over and you're going to see them crooked, all of these things. So we'll do an x-ray. We'll determine the degree of the angle of the scoliosis. If it is this greater than 40, let's make it 45. At 45 and up, we're going to have to do a surgical intervention. And that's where they take rods and attach it to the spinal column to try to hold that spine as straight as we can. Now, under 45, what they do is a very medical approach, which is putting on a brace. And you have three different examples here to show you what they are. And we wear them 23 hours a day. We take it only off to bathe and put a nice cotton t-shirt underneath for sweat. No lotions, no creams, none of that underneath again there. Okay. And then there's physical therapy. Exercise is going to have to be done. Now, osteomyelitis, I've mentioned it already. This is that open bone fracture. I see a lot of it. I see it where they've been outside walking and then in their big toe or the bottom of their foot, something got in there and they didn't know. And then all of a sudden their whole toe is swollen or the heel is swollen. And we do the x-ray, we see that little something going on there. And then we see them with the redness, the heat, the pain of it. And we'll do, of course, a blood culture and a complete blood count. And we're going to see those white cells up, that marked leukocytosis, right? So Osteomyelitis is danger. It can turn up to be, septic, general, go to your whole body, and septic shock is part of being septic. So when we see it and we can figure out that it is an osteomyelitis, it needs prompt, vigorous IV antibiotics, 3 to 4 weeks or several months, depending on how resistant and where it is and how long it's been there for. Now, it's usually a staph infection we're fighting. What are those big IV medications we use for staph? Isn't that vancomycin? Isn't vancomycin an aminoglycoside, which means peak and trough levels? Because we're monitoring the kidneys and the liver, right? Excretion and absorption. Very, very important that we do monitor that very closely, because then you'll end up with, your kidneys failing or your liver failing. With osteo, we try to keep bed rest on them, pain medicine, depending on the, where it is and the painful of it. It could be from Tylenol up to something a little more. And one of the most important things, especially in children, is that nutrition. What aids in healing? High protein. So this child would be on a high protein diet. And again, they're immobilized. So this child needs to be somehow mentally stimulated somehow, okay? Ewing sarcoma is a tumor in the femur, the tibia, ulnar, humerus, even in the scapulas. You know, this is a tumor. It's rare. It happens. And again, with it, we're going to do radiation, chemo, try to take out wherever that piece is if we can. And then if it's not metastasized, it's a better chance of, curing it, remission. Now, JIA, very similar to this stiffness, especially in the morning after sitting, but there's a couple key other stuff that goes on with it. We usually see it start somewhere between 1 to 3 years of age. It's very hard to diagnose. I've shared with all of you, I do have rheumatoid arthritis. Do you know how many years it took for me to be diagnosed? It was 8 or 10 years. I didn't even know at this point how long. And they kept running me through, it's this, it's that. And I'm like, no, it's this. There's not really many tests for it. So what do you see? Well, in the morning, really stiffing. You're very stiff. And then you can't walk because your hip joints are stiff. So you'll have that shuffling, that stiffness walking in the morning, and a limp. Again, depending on the rheumatoid arthritis, there'll be joint swelling. I mean, we've seen the pictures of hands all crooked and toes all crooked. That can happen too. And the one thing that we're not really made aware of is this uveitis. You can have problems in your eyes. That's why they should get to an eye doctor every year. As I said, no definitive tests. Yes, we can look at SED rates. We can look at the C-reactive protein, which measures inflammation. We can do the ANA, or rheumatoid factor. I've had ANA positive, negative, positive. I've had RA factor negative, positive, negative. It's all over the place. There's actually one now that finally diagnosed me. It's called a CCCP. I don't know what all the little initials are right now, but I was like off the chart high. And they're like, oh, yeah, you're right. You do. I'm like, well, I've been saying this for a year. Please listen. Now, there are times, GIA, the normal, that typical pain, but there's times where it gets severe. It doesn't matter, adult or a child. There's times where there's this exasperations. And because your body's trying to help, you'll see those white blood cells. Leukocytosis comes on. So there's no cure. You have to deal with it, right? Our goal is to try to prevent those deformities and keep the body moving, that's preserving the function. Relieving the pain, well, NSAIDs are the best thing to use for that. It's an inflammatory, so it's a non-steroidal anti-inflammatory drug. They'll also put you on some methotrexate, whether orally or injections, and then some sort of anti-rheumatic drug. I think the one thing we all think about first with JIA or rheumatoid arthritis is Humira, Enbrel, Cimzia, and then there's infusions and Remicade and Orencia, and I could go on and on and on. So there's many different things. Now, just to let you know, for information, just like antibiotics have different categories of antibiotics, one for this or for that, so does rheumatoid arthritis. If this one doesn't work, they can put you into another classification. I've been on 10 already. So this is the way why I know. So what do we need to do? Well, let's get up and move. Okay. Physical therapy, occupational therapy for young kids. I'm in the pool as much as I can because I'm weightless and I'm moving and I love the water. So it helps keep those joints moving, relieves the pain. And again, with children, always it's good nutrition. And the other thing for those times where it hurts, some children like heat. I do not. I prefer cold, but either or, whatever helps the pain. Now, we've talked about the body attacking its joints. That is JIA. Now, the body's immune system is now attacking all the organs, right? Whether it's the skin, where the rashes, right, on the cheeks, or the brain, the heart, the kidneys, all the organs there too. It's usually those girls somewhere between 10 and 19. Maybe it's that hormone that goes on there, or it could be a couple other things. One of the big ones is actually overexposure to sunlight. As somebody who works and lives in South Florida, for me, that's important to understand so I can teach. So I gave you a picture of just a little red splotch. Now I'm giving you a picture of other ways that the skin butterfly rash can present itself. Usually lupus, they don't know they're getting it. And all of a sudden, they start having different symptoms. It's usually when they have something like a seizure, or sometimes this pleurisy pericarditis there that gets them there. I mean, they're going to have some joint pain, but it's not as severe. It's trying to catch it as soon as we can. Our goal of treatment, again, is to prevent the body from attacking its own organs. This child probably is going to be on some sort of steroid and maybe other medications to try to slow down the body from it. And of course, it's going to be protecting them from the sunlight too. So let's go back to this fracture. Kristen, 10 years of age, sustained a fracture in the epiphyseal plate in her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that what? What are we worried about with epiphyseal plate fractures, wherever it is?
Is it bone growth?
Absolutely. Always our concern about it. And if they get into that growth plate, you're like, oh, mom, this child's going to need surgery. You just know by where that fracture is. Neuromuscular, musculoskeletal dysfunction. What do you think about with neuromuscular? What's your first disease you think of? Isn't it cerebral palsy? Cerebral palsy and the epilepsy that could be part of it. This is all, neuromuscular. And we know that it's abnormal muscle tone and coordination. Why does it happen? Well, it could be abnormalities in the brain, could be where blood supply was not where it should be, that vascular occlusion, low birth weight. And what low birth weight? Well, remember when they're born, especially premature, that's a low birth weight, their brains are very fragile, all the vessels. And sometimes noises, touch, jarring, their cribs can cause those vessels to bleed and cause hemorrhages in the brain, which can cause cerebral palsy. The other thing I've seen a lot of is some sort of hypoxic episode at the birth time. That is the other thing where they tried to have a vaginal delivery. They couldn't get it. They had to go for an emergency section. They couldn't get that kid up quick enough, and they had some hypoxic moment. So, how do we diagnose cerebral palsy? Well, sometimes we don't know, right? Why are we doing all those developmental milestones? If they're not meeting them, we need to find out why. Now, it could be we're finding out there's a mild cerebral palsy here. Because remember, you can go from mild to severe. So they don't all present the same. When we think of cerebral palsy, I think of my little Jonathan, where I did clinicals for Fortis for peds. This is a little boy spastic cerebral palsy, hypertonicity, poor posture, difficulty maintaining balance. This child would see me, the arms would go up and they'd be tense and he'd be smiling and his jaw would be so stiff. It's part of the spastic cerebral palsy. Now, these children really need good safety, right? You need to make sure he didn't walk at all. This is one that was very severe. We had to strap him into the wheelchair so he wouldn't squiggle out. And, there was other children that we had with cerebral palsy that we'd have in walkers and we'd have them in foot braces and stuff, and we would get them walking. So all different levels again there. So what do we see with cerebral palsy? Any level of it? Well, there's going to be delayed gross or fine motor development. They're not doing the way they should. They're not turning over the way they should. They're not lifting their head up the way they should. They're not responding to the startle reflex the way they should. All of these things will guide us into some sort of diagnosis. So, what is our goal? Well, Johnson was nonverbal. In fact, he couldn't even eat. He had a gastrostomy tube for feedings. But that little young man won my heart. It was his expression when he saw me, and the March of Dimes gave him a little computer pad, and he could type on it what he wanted. He knew what to do and how to talk to us. And I thought that was pretty neat. Also, he could learn through it. Now, when I was in high school, a long time ago, I used to go and volunteer with the Cerebral Palsy Foundation. And we didn't have physical speech and occupational therapy like today. We would get the children up, we would get them bathed, we'd help them feed, we'd help them watch TV. We didn't educate. Jonathan, the 7-year-old little boy, knew his colors, knew his shapes, and he knew their his numbers. It's quite amazing. So we want to make sure that we can do that for these children. Now, how do we help them? How do we get them around? Well, ankle foot braces, like I said, that one boy could wear because it helped him keep his ankles and his feet supported. Sometimes surgeries can be done. Now, Johnson actually did have some Botox injections, to try to help him with the spasms. They also gave him Parkinson medicines, the levodopa, carbidopa things to help those jittering, shaking, something new that they were trying. I also told you that these children are high risk for seizures, right? For epilepsy. What's one of the main drugs we use for epilepsy is phenytoin, Dilantin. Big side effect, gingival hyperplasia. Therefore, good dental hygiene. And of course, keeping them moving, keeping them stretching. Prognosis, we know, depends on the severity of them. And the other part of cerebral palsy is these children will be home. Now, there are, thank goodness today, these places where these children can go during the day to learn, to have their speech, physical, occupational therapy, and be loved by a great group of people, but they still have to go home. So we got to make sure that the family knows what they're doing and that they know to keep them safe, have to have the equipment, how to do the medications, et cetera. And Families do appreciate everything that's done. Do you remember in pharmacology that they told you have to take folic acid 1 month before you get pregnant to prevent neural tube deficits? Well, this is your neural tube deficit. It's anywhere from the head to the spine. Now, when we talk about it, we're going to talk about the myelomeningocele, that big blob at the bottom of the spinal canal. Let me explain what's in that blob. The lower extremity nerves and meninges pull up and pull out, and it keeps in the meningeal sac. But what did I say? Those nerves, it's pulled up and out. So there's going to be decreased nerve sensation in the lower extremities. What's also in that lower extremities that we have to be concerned about? Bladder control and bowel control. Those are two big things with this. So they say it's due to a couple different things, maternity obesity. We're not totally sure. They're always looking for reasons for this. So we get this child. Let's say you're working in the delivery room and you're in that newborn ICU where you want to work, and you're getting a child with a myelomeningocele. Well, you need to have immediately some sterile, normal saline dressings, wet, to go over it, to keep it intact and keep it from infection. That's number one. Another thing we've done since the beginning of time is we've always made them latex allergy. If they're latex allergy, because they are getting multiple surgeries. Many of these children are going to, because of this urinary, not feeling it when they're full, and they're going to need caths every 4 hours. They're going to have catheters and gloves every 4 hours getting urine. Many of those kits are latex. So we make sure today that the latex from the very beginning, latex allergy, don't use it. And of course, we're going to always watch their bowels, because bowels, bladder, same area, same type of nerves. As I said, it's that folic acid, right? We need to take it. Now, spinal muscular dystrophy. We talk about a couple types here. This Werdig-Hoffman, it is, again, an autosomal recessive trait, and it's called the floppy infant. This is a child that is progressive from the moment they're born, progressive weakness. And they usually, by about 2, they're dead already. What happens is there's no cry, they can't cough, they can't lift their head, they can't move, they sit in a frog type position, and that's the way they are. So that's a muscular atrophy. That's progressive weakness. Now, Duchenne muscular dystrophy is the most tested of all the dystrophies. This is the one that my students have told me it's on the NCLEX. I know it's on the HESI. What is Duchenne muscular dystrophy? Well, it's a name of muscles that don't work right, okay? It's called pseudo-hypertrophic muscular dystrophy too. And why hypertrophic? Because the calf and the arm muscles get really thickened and big, okay? The muscles they're not looking right. Now, mom passes this. It's X-linked. It's male children, and we usually start to give this diagnosis between 3 to 7. Now, these children, cognitively, they're not normal. They are cognitively delayed, okay? They do get, where they can stand up, and then they start to make steps. And then all of a sudden, they start going backwards and falling down. It's a progressive muscle weakness and wasting that you see from them. These children tend to be overweight. They're not moving the way that they should. And usually by teenagers, even with aggressive physical therapy and dietary and all of these things, their respiratory, your diaphragm is a muscle, right? And your heart, progressive muscle wasting, it fails. Now, how do we diagnose this child? Well, it's all about muscles and muscles working. So, how do you test muscles working? Is something called electromyography. They can put either little needles in or just those little skin tabs. And what that little tiny machine does is they will put a little electrical zap onto that area and watch the muscle contract. How long did it take for that muscle to contract? Well, they do it all over the body. What's the problem after they do it? It's like this child just done the 10-mile race where they haven't exercised. So they come back and they're really sore. So, number one, prepare the mother, the child, if they're aware enough, and make sure they have some Tylenol or some Motrin or something, right? They do have, as I said, their gait is waddling, they're falling, and then they do what I do every time I'm on the floor. It's called Gower sign. It's when you stand up and you slowly take your hands and go up your legs to stand up, right? It's like, oh, I can get there. The Gower sign. The lordosis, again, that's that lumbar spine. Again, those big muscles in the arms and legs. And of course, they're going to, as I said, have some mental impairment with it. So, as I said, goal, we want to maintain their flexibility and movement as much as possible. So it's a lot of, again, physical speech, occupational therapy, keeping them moving. And if this family wants another child, genetic counseling, very important. Now, Guillain-Barré, it is children are less often than adults, but we see it in children. It's called an infectious polyneuritis. It's a viral thing. It's not a bacteria, and it attacks neuritis, nerves. And it starts from the feet. And then the numbness in the feet goes up, and the nerves get numb. Then it affects your bladder, your bowels, and then it gets to your phrenic nerve and it stops working. So now you're on a ventilator, okay? So, what do we do? How do we manage these children? So, we've seen the feet coming up, muscle tenderness, paresthesia. We're starting to see loss of lower extremity reflexes. And now we're seeing incontinence. We're going to be watching their respiratory effort. These children, if they're in a hospital when it's going on, they're not always. They need to be on some sort of respiratory monitoring, a O2 sat monitor, as simple as that, on a cardiac monitor, monitoring respiratory rates. So how do we treat it? Well, it's all symptomatic, but you might give steroids. Some they do to try, but it's IVIG, and then they clean the blood, this viral component, with plasmapheresis, which is very similar to dialysis, but it doesn't remove urine. It's a little different, okay? We will be monitoring, of course, their respiratory status. These children will be on a ventilator. If they're on for more than 2 weeks, they'll be getting a tracheostomy and we'll just preventing complications. We know that Guillain-Barré, they're starting to get better when you start see them breathing over what the ventilator rate is set at. And then you'll see it, watch it go down. But there's a long recovery, depending on how long that they couldn't move, okay? I had a nursing supervisor. She was in her 20s who ended up with Guillain-Barré, and I watched her whole thing go on. Now, tetanus. This is stepping on that little rusty nail, right? Well, we call it lockjaw. Why do we call tetanus lockjaw? It's all of the muscles in the neck and the mouth and oral pharynx get stiff and it just swells up and it closes off your airway. It's that tight, painful, okay? So when these children have some sort of wound, and we start seeing these sort of things going on, we can sort of guess probably this is tetanus that's occurring. You're going to see the obstetonus, the difficulty swallowing. Remember, everything here, the tetany, the muscle spasms, they're not breathing. Because they're not breathing, they're going to get full of secretions. Their lungs are going to be full of fluids and atelectasis and whatnot. But remember, they're alert underneath all of this. They are trying to breathe and they're anxious, so rapid heart rate, diaphoresis. Now, these children are sick. Many of them die. They say, though, if the child stays alive for 4 days, probably the kid's going to make it, but not guaranteed. So, what do we do? Well, number one, how do we prevent this? Well, getting the tetanus vaccine. You know, when I first started getting the tetanus shot, I think it was every 2 years. Then they changed it every 5 years. Well, today it's every 10 years, and they give it with diphtheria now. So every 10 years, we're getting the tetanus shot. Any wound that we get should be clean, soap and water and some sort of antibiotic ointment put on it. That's what we should do and how we should treat it. So these children with tetanus, remember, it's respiratory, it's all up here. We're going to be monitoring, of course, fluid and electrolytes. We're going to be giving tetanus immunoglobulin therapies. We're going to be cleaning the wound. And these children will be paralyzed and sedated, as in that muscle tension is so painful. We'll give that child something where they can't move at all, and that will release that discomfort that they're feeling. Botulism is giving honey or light or dark corn syrup to an infant. Now, I've seen two books, two different. They say that you should be 2 years old before you give honey or dark corn syrup. There are some cultures, and I've heard it before, where child's not having a good bowel movement. Grandma will say, well, just honey, that will help. Well, we don't know if it's been pasteurized properly, how long it was stored before you bought it. You know, there's too much ifs with honey. So only getting it when they're older. Again, very similar type things that go on: weakness, dizziness, headaches, speech, vomiting, again, respiratory paralysis, all from some honey. So we give IV botulism, immune globulins, we take care of their lungs, always nutrition, any kid who's, in any of those conditions. And we'll just keep going until that paralysis will slowly disappear. Now, I worked in an ER for the last 10 years of my career in the hospital. And I was one of those trauma junkies. I loved being the primary nurse. I liked being in control. I kept it calm. Now, spinal cord injury. Let me tell you the one that I'll always remember. 16-year-old boy, we get a call. We can hear it, going out for rescue to go pick him up. 16-year-old boy was playing baseball, slid into third base, head hit the knee of the defender, and they heard a crack. He fell on the ground, his right leg went numb, and his left was tingling. There was healthcare professionals there that kept him straight and flat. They got him on a board, a collar, they airlifted him and came in to me in my ER. These children, the biggest thing is we didn't know. And if those people realized what they were working with, I would have been afraid to touch him. He had an angulated, literally C5, C6 was in an angle. That spinal column, that cord was almost cut. It was hit, but it didn't sever, okay? So our goal always is that proper immobilization. What was my goal as I took them through an MRI through the ER, which is the only MRI I've ever done in the ER, was on this little boy. I was in charge. I had his neck. You're not moving without me. Now, let me tell you the end of that story of that boy. 2 weeks after he had the injury, I went up to his room in the hospital to visit him. He remembered me because I kept him calm, quiet, and I answered his questions. So he wasn't as afraid because he had somebody he could sit there with, okay? He was moving his left leg completely, had slight weakness on his right side, and he was going to go into rehab therapy the next day. And he thanked me so much for everything. Well, I'll take it a step further. 1 year later, he came into the ER looking for me to hug me. He was perfect, no deficits at all because somebody made sure proper immobilization. Always remember that. Somebody falls, always watch their spine. Don't move them. It is so easy to take and turn them and be crooked with the turning, and that will be the end of their motion. So that progressive infantile spinal muscular atrophy, and the most common paralytic form of floppy infant. Do you remember the name of it? It's wording. Don't worry, I won't make you suffer. So, any questions so far? Who wants to do a cahoots and win today? Catherine does. Jennifer, Everlyn, you want to win today, don't you? All right, let me get it open. Give me 1 second.
I don't have a phone.
That's okay. Just watch and pay attention. How's that sound? I am going to run quick to the ladies' room. So who else is coming? Only 5 of you? Come on, you could do better than that. Who else is coming? All right, you're stubborn today. We'll get going. Week 9, musculoskeletal, neuromuscular dysfunction. And Jamika, that's your scribbles on the machine. A multi. What is the priority for a nurse to assess following a cast application? So remember all the 6 Ps, okay? The 6 Ps and the rice are things that you need to know. It's a basic type of concept there, both of them. A multi. Patient teaching for a child with a fractured bone that has had a new cast applied. So that cool hair dryer works really well. No powder, no lotions, please, no hanger, and no swimming with the cast once it's dried. You know, I have heard they're working on one that can go in the water, but as of right now, no, we don't have it. What should the nurse monitor after a soft tissue injury, like a bruise? It's only a little bruise. Always look at neurovascular signs, okay? Vital signs, not as much. We're looking at circulation, and that is the priority there. A fracture that penetrates the skin is called what? And that's called your compound one. Yes, very good. Another multi, Bryant's traction. What is that little girl with her feet up for the trying to take care, put her bones back where they need to go? So these kids they can't be too big. So 30 pounds can hold them up good. That's skin tractions for the hips. We always have those hips up a little bit. I apologize for the spelling errors. And of course, check the skin for breakdown all the time. Any of these, the Pavlik harness, any of these tractions, checking the skin on making sure it's not broken down. Very important nursing thing. What's the priority nursing care of a child with a compound fracture? Priority. So you have a compound fracture, it's open to the air. Priority is IV antibiotics. Yes, you're going to be giving pain medicine. Yes, you're going to be neurovascular checks, but we don't want it to become a septic shock. So IV antibiotics is your priority number one. What is priority nursing care for a child who fell off a second floor balcony? When we talk about a fall, we number one is that spine, right? Strict immobilization of that spine. And then after we do that, of course, it's neuro checks. Very good. Principles of managing a soft tissue injury include what? Sprain, strain. What do you want to do? That's your rice. Rest, ice, compress, and elevate. Very good. And then immobilize it somehow. An apesio plate fracture in children may what? Epiphyseal plate. So that's your growth plate. Again, that's where we have to be really careful about the growth of the bones. We want it straight. We don't want it crooked. We don't want one shorter or longer. So absolutely, very much looking at the growth of the bone. What findings for a patient in skeletal or skin traction indicate peripheral neurovascular impairment? So when you think of skin traction, mostly I think of Buck's traction, and I think about that fractured femur like this picture. So what do you think? Neurovascular impairment. You don't feel a pulse, right? You don't feel a pulse, or those other 6 things there, but that's one of them, yes. A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? So you have a child, fractured femur, they placed them in Buck's traction before they can go to surgery and put the rod in the femur. You need to know what and how to care for this child. So you're going to document the weight that's there. People come in and out of there all the time. So weights can be removed because people do stuff like that. You never take the weights off, you never reduce the weights. And the big thing, make sure that it's hanging. It's have equal constant pull. It's hanging properly. Yes. When caring for a 9-year-old Buck's traction, what action by the nurse is correct? So what do we need to do? Is always checking capillary refill, right? And if we're seeing decreased neurovascular signs, decreasing pulses, we're going to call the doctor. Something's going on. What position do you put the legs in an infant with hip dysplasia? And it's abduction with the B. Yes, it is. What statement by parents indicates more teaching regarding their 2-year-old infant with club foot? So remember about healing and the infant. We need to start that treatment now, quick, because their bones are flexible. They will heal good if we started quick. Every week they have to come in for it, and they're going to need follow-up until they're grown. Once a month is way too long, and now the foots are healed improperly, and then sometimes they need to have surgery and break them open. So doing it as soon as possible and every week changing that cast. Ponseti method. A multi. Osteogenesis imperfecta. OI. These children with proper care can live into adulthood. Now, I've actually seen some documentaries on parents with children with osteogenesis imperfecta that have been arrested for child abuse. And then they found out it was OI. So remember, that's something to keep in mind if we ever see this. Its long bones are crooked, it's brittle bone disease. And if you did aggressive physical therapy on that infant, you'd be breaking bones. We don't. Okay. We just tried to put them in a position, that they can get up and get out of bed and sit in a wheelchair and get around and mobile and see the world, right? Not aggressive. What is the pathologic cause of leg calf birth disease? Number of set femoral head. Oh, it's getting fuzzy. What does that mean? What's happening? It is an ischemic, which means a lack of blood flow, aseptic, no infection, and it's necrotic. It's killing the head of the femur. That is leg calf birth disease. What is kyphosis? So kyphosis is that humpback that we see, yes. It's up into that cervical, maybe the top of thoracic spine. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? So a Mora reflex is a startle reflex, has nothing to do with hip dysplasia. Very good. Positive ortolani, those asymmetrical skin folds, and a Babinski is just a reflex of the heels. It's not, I mean, everybody has it from infant to adult. Lordosis is described as so lordosis is that inward curve of that lumbar spine. Your Duchenne children have this. Scoliosis is so it's that S-shaped curve, right? So we can treat scoliosis in many different ways. So adolescents with scoliosis have up to a 45-degree of curvature of the spine would need to do what? Up to that point. I didn't say after 45, I said before. What are we going to do? So up to that point, we're going to do a brace 23 hours a day with physical therapy, and underneath to wear a nice cotton t-shirt for sweat with no powders and lotions and that stuff underneath. A multi. Teaching for the child with scoliosis with less than 40 degrees of curvature. So it's all the above. Wear the brace, cotton shirt, no lotion. And again, physical therapy, it strengthens the muscles to hold that spine where it needs to be. A multi, a Pavlik harness. So Pavlik harness is the infants with developmental hip dysplasia. It holds it into abduction. We're going to check the brace. And the one thing about infants, we're going to make sure underneath that we massage those areas to prevent skin breakdowns. What is osteomyelitis? And that's a bone infection. Usually something's gotten in there, created something, an infection, and it goes to the bone. Very dangerous. Goals of juvenile idiopathic arthritis include The whole thing with any of these arthritis is to reduce that joint pain and swelling, and especially in children, to keep them up and moving and being, quote, normal. A multi. What might you anticipate for a child diagnosed with JIA? Well, your facial rash is lupus. It's the uveitis, which is the eyes with rheumatoid or JIA can cause. Of course, it's the joint disfigurement and, of course, the weakness, difficulty, especially in the morning. What is cerebral palsy? So cerebral palsy is all about body movement, muscle coordination. It can go from that spastic cerebral palsy to mild. It's just that ambulation and body movement. It can't control it. A multi. What are signs and symptoms of spastic cerebral palsy? And it's everything, the poor posture. That's why we have to make sure we use our seat belts and buckles and harnesses with these children. Those poor fine motor skills because they can't control. And of course, hypertonicity and poor balance. They don't control muscles. A multi. When feeding a child with cerebral palsy, what is important to remember? Remember, there's poor muscle control, especially in that spastic. I mean, Jonathan had a G tube. He couldn't eat orally. But if we were to feed him orally, keep the head of the bed up, prevent aspiration, and give the kid enough time to eat because they really working hard at controlling their mouth and the chewing and the swallowing. And of course, suction at bedside always, right? And you would thicken the fluids. Thin tend to choke and aspirate. Myelomeningocele, it's that big blob, right? I had a little boy, Emmanuel Louis, as an infant with a myelomeningocele. And I remember the mother being so upset and crying. I remember sitting her down in the chair, wrapping him up, and I said, "Here, hold him." And it's 14 years later, she came back to hug me and thank me for that day. Anyway, it is a hernia of a spinal cord meninges. It means those lower ones are picked up, ripped, and pulled out. So again, you know what you're going to see, deficits, nursing care. A multi. What can help a child with lupus erythematosus prevent exasperations? I mean, we know stress, eating right, all of these things. Yes, but what's one of those ones? So decreased exposure to sunlight and sunscreens, of course. And remember, it's the body attacking itself. It's an immune compromised child. So prophylactics, absolutely. Infants with myelomeningocele demonstrate what? It's sensory and motor, absolutely, because those nerves have been stretched, right? Myelomeningocele have decreased motor and sensations of lower extremities. The nurse should monitor closely what? What are we concerned about? About no sensations, minimal sensations, and can't move the lower extremities. Number one is urinary retention. Yes, we're going to look for skin breakdowns, contractures, and foot drop, but every 4 hours, we might have to do a catheterization on this child, right? So urinary retention is number one here. A key feature of Duchenne muscular dystrophy is and if you're not looking at it and don't remember muscular, muscles, dystrophy, not working, muscles not working. What do we need to think about? Key feature, it's a progressive muscle wasting. Yes. What is one of the procedures that a child with possible Duchenne's may need to diagnose the condition? Remember, we're looking at progressive muscle weakness. And it's called that EMG. Remember, when they're done, these kids hurt. It's like they have run the 10-mile marathon. So make sure that they're aware it's going to happen and to medicate them for that. How is Duchenne muscular dystrophy inherited? And it's mom, X-linked recessive, yes. In caring for a patient with Guillain-Barré, the priority concern is what? Remember, this is one of those neuritis things. It's a nerve thing. And we're worried about that phrenic nerve, worried about the airway coming from the feet working up. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? Remember, I tell you it starts with the feet and it starts with the shuffling and stumbling and falling. And then it goes into maybe the knees hurting and then being incontinent and constipated. It's called ascending, okay? Starts from the feet and works up, and it's bilateral, okay? When Guillain-Barré, it's done and getting better, it's descending. All of a sudden you would breathe. All of a sudden you would feel your urine in your bowels, and then all of a sudden you'd feel your legs and your feet, etc. A multi-select. Treatment for Guillain-Barré include they've found out with Guillain-Barré many times they've had a viral disease 21 days before, and it is that virus that goes in and attacks the nerves on these children. So antibiotics is not one of them. It's the IV immunoglobulins. Give them as much immune help as they possibly can. And number one, absolutely, is that respiratory support. Phrenic nerve's not working, they're not breathing. I mean, heparin might be used to prevent blood clots, whatnot, but the treatment for just Guillain-Barré is IVIG and respiratory. What types of cerebral palsy causes hypertonicity and poor fine motor skills or gross motor skills? And it's spastic, yes. What priority action should a nurse take to a patient with a suspected spinal cord injury? And yes, immobilization of spine. You heard me loud and clear. Good. You should get a tetanus shot, every how many years? And it's every 10. Excellent. Good job. Which is a symptom of tetanus? Your rusty nail. And it's that lockjaw. It's all those spasmings of the muscles, and it just squeezes the airway and you don't breathe. Very, very sick child. And last questions. The most common cause of spinal cord injuries are what? It's all about number one is always motor vehicle, right? Driving, sports, those things. Yes, very good. All right, we made it through another week. Josie, good job, Josie. Number two, Jen. Good job, Jen. You listened well. Lolita, good job, Lolita. Number four, Catherine and Kelly. Very good. So remember, next week is going to be your last exam, exam 3. All of your reviews will be out there by probably later on tonight. So if you want and you need help, you can ask me to go over concepts that you don't know. So just make an appointment with me. We can go over it so that you do understand. All right. Anybody have any questions, comments, concerns? Remember to get your pediatric assessments if you want any changes in it. If you haven't done it, please get it in. I've sent reminders. And any other comments, please get with me if you need to. So have a good weekend, guys. I'll see you. Good luck.